Okay, thank you. Thank you.
If you want to comment on some points, then we can start the second session.
Then I'll request the speakers to answer in the chat box so that we can go on to the second question. We can go on to the second session.
Yeah.
Yeah. I'd like to thank all the speakers for giving a very good. Yeah.
I also thank all the speakers for their very valuable lectures on metastatic spine tumors. Now, as the WFNS Education Committee, we will start a new type of lectures, tricks from the masters. First time, I'm very proud of having Dr. Robert Spetzler with us, and I will tell a few things about his CV. He's one of the world-renowned neurosurgeon who has specialized in cerebrovascular disease and skull-based tumors. And he has been involved in pioneering the technique of hypothermia and cardiac arrest for the treatment of difficult brain lesions. He was born in Germany, and he has moved to United States at the age of 11. And he has finished the Northwestern Medical School in Chicago, and he has graduated training in Wesley Memorial Hospital in Northwestern in Chicago. He completed his residency in neurosurgery at the University of California, San Francisco, and received board certification in 1979. And he has received many awards from different societies and different countries. And he has published more than 300 articles and 180 book chapters. And he's the co-editor of the Color Atlas of Microneurosurgery. I will moderate the session with my dear friend Alvaro Camparo, and we will have 3 young neurosurgeons who will ask questions about how to proceed in their career in the future. Yes, please, Professor Spetzler, you can start your talk.
Can you hear me okay?
Yes.
Yeah. Mehmet, thank you for that very kind introduction. It is a privilege to address especially the young neurosurgeons, to hopefully pass on some of the experience often obtained by making mistakes so that they don't have to repeat the same mistakes. And so I'm going to share sort of what I have learned and some tricks and lessons. And I'm going to use as my substrate cavernous malformations because they respect no boundaries and they challenge us many times in how we get to certain parts of the brain, especially deep parts of the brain. I have greatly enjoyed working with cavernous malformations, and they have taught me an enormous amount. What are my general recommendations? I think we need to start off a little bit philosophically, and that is to have mentors, people that you look up to, that you copy, you observe, you study, you remain open to what others think and learn from them. There are many roads to Rome. You have to choose the one that works best for you. Details matter, and I'll spend a little time on that. And then very important is that when our residents or fellows leave the nest, I emphasize to them, start with easy cases. Do well with those cases and your reputation will grow and you will not start off with a disaster that will haunt you for a long period of time. Progress slowly. Be confident enough to stop. By that I mean is when you are looking inside the brain and you see that you're not going to be able to finish this successfully, stop and back out. It takes a lot of ego to tell the patient, I'm sorry I wasn't able to finish this, but your health is much more important to me than finishing something that I thought might hurt you. And then finally, enjoy this incredible privilege that we have been entrusted by patients to take care of them. So I had my own 3 professional mentors that I try to emulate. My boss, my chairman, Dr. Wilson, who was dedicated, focused, was an incredibly hard worker. Ghazi Yassergil, who was a surgical virtuosity. He trained a whole generation of neurosurgeons. And then finally, Charles Strake, who many of our young colleagues will not remember, but he was a giant in neurosurgery. He did more basilar artery aneurysm than anybody else. But what I considered for him as a mentor is that you could approach him. You could be a medical student and you could sit next to Charlie and have a conversation. And I absolutely loved that about him. So what did I learn from him, mentors? Well, you have to have a passion for your art. You have to have self-control. You have to be a team player. You can't be solo anymore in today's world. And you need to be a mentor. Being a mentor, you also learn a great deal. And I think if you want to be in academics, you have to read, not only read, but you also have to publish and you have to present. And most important is you have to learn from mistakes. When we have morbidity and mortality conference, the most important thing is not to point a finger and make somebody making a mistake, but actually learning from that so we don't repeat it. Share success, own failure. Mentorship and technical excellence, we need to practice, practice, practice. And today you have courses, you have online courses like this, and you have cadaver courses, you have technical courses. You can practice experimental bypass with very little material. You can travel and observe, copy what works for you, and reject what doesn't. Be a team player, very important. And then analyze each case before you start. And be prepared for all points of failure. I can't tell you how many nights I was not able to sleep because I was doing a big case the next day, and I would go through it, and I'd see this mistake that I could make or this mistake. And by that, you are sort of prepared when something bad happens, what you're going to do next, and contribute and be a mentor. Everybody has their own way of doing it technically, and I can tell you that for me, I like the sitting position. I like the armrests. Just use this here so you can see. And I like the foot pedals that give you additional control for the microscope. Personally, I need to have a mouthpiece so that I can move the microscope all the times. Details matter. I just mentioned a few of them. Position for the patient and the surgeon. The patient has to be positioned properly so you're not compressing any veins. The surgeon has to be comfortable enough so that if it's a long case, you have no trouble performing it. All of these are important, and all of them play a role. Retractorless surgery. We've published a lot on that, and it's not a new concept. My point is that when you start an operation, don't just automatically place rigid retractors, but rather use what I call dynamic retraction, where you use your instrument to mobilize your exposure. If you think that retraction doesn't do anything to the brain, I want you to look at this little video. Nothing is done except to hold the dentate ligament upsliding. Notice how there is no blood flow underneath that tiny little bit of tension. And when you release it, it comes right back. The brain is very, very sensitive to compression. Approaches. Well, I've said it 1,000 times, exposure is everything. If you get there, if you can see it, then you can take care of the problem. For cavernous malformations, we've learned that you have to present the venous anomaly. One of the first cases I ever published, I took this large vein in association with a cavernous malformation in the posterior fossa. Patient had fine for a few hours and then that had a massive venous infarct because we didn't realize the importance of it. That mistake should never, ever happen again. Image guidance is important, monitoring, sharp dissection, burst suppression, anatomy, 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 and as I mentioned, avoid rigid retraction. We don't have time to spend a lot of time on anatomy, but I can tell you that what makes Yasser Gil a spectacular surgeon is because he knows his anatomy intimately. When he looks at the surface, he already knows what's underneath. We have a lot of tools these days that can help us with that. And if you just think of lesions in the same portion of the brain, even though they're very close physically, they have totally different approaches. We published on the thalamus, and we've divided into 6 separate regions, each region requiring a different approach to get there. And they're sort of summarized here. I won't spend any time on that, but I will show you some cases. We have now, with intraoperative image guidance and our incredible magnification, we can go to anywhere in the brain. And so we want to avoid retraction. We want to use ICG wherever necessary, and we want to pick the right approach. Oops. Oh, here we go. So we want to avoid retraction. So this is sort of the setup that I like. So we have image guidance, we have the microscope, we bring it in, and then we've added on lighted instruments. When you are going down a very narrow channel, you lose light because the light comes in at a different angle than your visual line of sight. And it depends on how far down you go as to the angle. It goes between 3 to 6 degrees. And so by adding light, you can see beautifully even in a very small corridor. So we analyze each case. So we look at this particular cavernous malformation, and we have to decide which approach to use. Retrosigmoid, not unreasonable. OZ, S supracerebellar infratentorial midline, lateral, Kawase. And for this particular case, if you look at this angle, a lateral supracerebellar infratentorial approach is really the best. The tentorium is a beautiful structure because it gives us so many different angles to get to the deep portion of the brain. All we need is a small opening. Tentorium is up here. No rigid retraction is in place. Patient is not in the sitting position. We get down to the ambient cistern. We open, let out a little bit CSF. We just take our time until we see our pathology. And then we just take out the cavernous malformation piecemeal. And this is no rigid retraction in place. Patient is sort of a lateral angled position with the head flexed, and we take out the lesion. And it comes out very readily. So decision-making, here's a medical student with a sudden onset of severe headache, apoplectic event, and she has this MRI scan. Now, what is most important is when we look at this is obviously very, very close to the fornix. Great respect for the fornix, and we need to preserve the fornix. She has excellent functional memory. So the first question we have to ask ourselves, do we observe this patient or do we offer surgery? If surgery, what approach? Interhemispheric? Lamina terminalis? If interhemispheric, what position? Straight up, which is the classic way, or lateral? I like lateral because you have many advantages. Our eyes are horizontal, our hands are horizontal, and gravity will pull down the exposed hemisphere. So there are many reasons to go lateral. Here she is in the position, and then I use the table to make it completely lateral by angling it. Image guidance brings us right down to the lesion. Very straightforward. I won't spend a lot of time on this. And we take it out and we close. Just a little straight incision. The lesion is completely gone. Her exam is normal. She goes back to medical school a few days later. What about this one? You have this cavernous malformation. It has bled several times. You see it where it lies in the frontal horn. First thing we have to do is ask what approach. Transfrontal, perfectly reasonable on the right side. Interhemispheric transcallosal, difficult because you have to make this corner. Or contralateral, interhemispheric, through the cingulate gyrus, a direct approach. And that's the one we chose. So what we're going to do is we're going to put the patient lateral. We're going to identify where we need to make our opening in the falx. And so here's the lesion. Here's the exposure. Contralateral hemisphere is dependent. No rigid retractor in place. We use image guidance to decide where we have to make an opening in the falx. We make that opening. Make a little opening in the cingulate gyrus, very small. And we go right down to the ventricle. Beauty of image guidance, naturally. We just follow the track. And there's our little cavernous malformation, which has caused this individual all sorts of harm. And then all we have to do is separate it, get all the little veins that are part of the lesion. And then take it out. And it comes out very readily. And here we are all the way across. And we take it out. I want to be sure we don't lose it in the ventricle. And there it is. Very small opening. And that's how we went. For the spine, for the spinal cord and the medulla, it is also important to remember what we are capable of. We have basically three approaches in mind. The midline myelotomy, the one through the substantia gelatinosa or dorsal root entry zone, and then lateral between the nerve roots. So those are the three approaches. And just like in the medulla, the anatomy for the spinal cord gives you those three approaches: the lateral, the dorsal, and the midline. So here's a classic midline one. This was a familial case. They both had lesions in the same place. The son had a hemorrhage from his lesion. This is the father, but a hemorrhage from here, and he was in a wheelchair, a terrific person. But his dad, who had this exact same lesion, 6 weeks after this happened to his son, he insisted his come out, and that's what comes out. A little more challenging is the one that's off to the side. Patient also with arm pain. So here we are. Here's the dorsal nerve root. We make a little incision right along it. We get right down to the lesion. You notice just gentle retraction with your forceps. We identify the cavernous malformation. And we take it out in a piecemeal fashion. Even more challenging is this gentleman who went all over the world, had several hemorrhages, and here's this cavernous malformation. You can see that this time it's much farther anterior. So this time we're going between the nerve root. Here's the dorsal nerve root. Here's the dentate ligament right here. And so now we're going directly to the cavernous malformation. And you can see by when we pull it out, the different consistencies that represent the different ages of the hemorrhages. And then I always use a little counter pressure. This is a sucker. When you take your finger off, there's absolutely no suction. So you can regulate it very closely. And here's the post-op. You see the lesion gone. Far lateral. This is a very short course to really be talking about the intricacies of these approaches. But with far lateral, you really have different degrees of exposure depending on how much of the condyle you remove to get there. And so you have to decide again which tracks you're going to go in between in order to get to your lesion. So I'll just show you one. This is actually a reporter or an editor of the London Times. And she had this lesion that bled 3 times. And through a very small paramedian incision, we get directly to this angle. And you can see the vein that's associated with the cavernous malformation. We're in front of the medulla. You can look at the different colorations, the fluorescent orange and stuff, all different ages of bleeding. And because of this exposure, you require absolutely no retraction, no rigid retraction, and you remove the lesion. And then she wrote a book about an experience, which I recommend. It's on Amazon only, so we're reminded of what the patient experiences. We tend to go from one patient to the next and don't give enough time to what they go through. Suboccipital approach, I personally like to have the patient in the prone position. And just to remind yourselves, when you have a lesion in the base of the floor of the fourth ventricle and the patient is asymptomatic, that is not a surgical lesion. Here's one where the patient was very symptomatic, straightforward, came out very easily. I'm not going to spend any time on that. More interesting are the ones that are off to the side. That's the post-op here. Neurologically unchanged, but the patient already had a preoperative deficit. So this is more interesting. This is a cavernous malformation that's off to the side along the foramen of Luschka. So we're going to do a telovelar approach. And telovelar approach, this is the position. The anatomy is just incredible. And we just have to know this anatomy to know what we are capable of. So that's why the fourth ventricle floor is so difficult. But when we get off to the side, to the foramen of Luschka, we are talking about the middle cerebellar peduncle, which is very robust to incisions. So here's a pica coming up, feet are up here, head is down here, fourth ventricle. Put a little bit of gel foam in here to prevent any blood from going into the aqueduct. And then we just keep going lateral. Here's the gel foam going in. We just keep going lateral until with image guidance, and you'll see the white of the floor of the Luschka because it's obviously white fibers. We just mobilize, and there is the foramen Luschka right there, that white. Then with image guidance, once I've identified the direction I want to do, I make a very small opening. There we are, very small instruments, pituitary-like, but just micro. This is just millimeters opening. And we take the lesion out, comes out very nicely. Here's a little debris left behind, but it's gone. This one, I just want to demonstrate a very important point. I think here's a a patient with familial cavernous malformations, multiple cavernous malformation. Here's the lesion. Still has hearing in this ear. So what we want to do is we want to operate through a retrosigmoid approach, but we want to have our trajectory so it goes right through the middle of the cavernous malformation. Why the middle? Because we have equidistance then to the base and the top. This top, if we come in just here, is a long reach and we're going to hurt the brainstem. I can't overemphasize that point, going through the middle, and once you're at the end, you know we're at the end with image guidance. So here it is, fifth nerve. We go up on the brainstem until we get that trajectory I showed. This is the brainstem where the fifth enters. We make our opening, and this is a cavernous malformation that's very large, so we just keep taking it out and out. Make this opening. And we just keep taking it out until it's out. And here you can see the post-op, that's the hold. But most important, the hearing was preserved. This I include because I want to make a good point here. The key is the middle cerebellar peduncle, as I've mentioned before. So to get to this lesion, we want to open the petrosal fissure. Again, the patient is just in a lateral position, sort of a concord. You saw the lane of the Dandy's vein over here. I never take it. It's a very nice reminder never to over-retract. We have the lower cranial nerves, and then we open the petrosal fissure. It's just like the Sylvian fissure, except it's more fragile. So you have to be very careful to separate the cerebellar hemispheres. And then what we're exposing as we go between the cerebellar lobules, we expose the middle cerebellar peduncle. And here we go. We just keep going very gently, spreading the two hemispheres, opening the arachnoid plane that exists there. And now we're seeing the middle cerebellar peduncle. And then with image guidance, we know where to make our incision, make a little opening. And I really just wanted to show you that. And notice, no retractors in place. No retractors. And this is not the sitting position. And we take it out. And there's left a little air behind. This here is pretty straightforward. And I just want to remind yourself of the anatomy. Here we have a cavernous malformation below the medial lemniscus, cerebellum, temporal lobe. Tentorium sits right here. So this is no doubt what we want to do. So we want to use the tentorium, and we want to decide the angle. In this particular case, we're going to do the lateral angle because we want to get right here. And so here we make this little opening. We get down, let some CSF out. You notice the angle that we're coming in off. Look how far lateral we are. And then we get to the cavernous malformation. And not much to it. We take it out. Here you can see where we entered, way off to the side, and there's the empty cavity. What are the limits? Well, here's one that had been operated on previously somewhere else from a subtemporal approach. Patient was in a wheelchair, had more hemorrhages, and so we're going to use the same approach. This time we're going to have to open the tentorium because the lesion extends toward the foramen of Monroe. So we open it, and as long as we stay extra-arachnoid, we know that we're not going to injure the fourth nerve, which just lies just below the arachnoid. And then we make an opening in the medial lemniscus, and we get right to the cavernous malformation and take it out. There it is. And again, my point is to show you the approach, not taking it out. And there's the post-op. Lesion is gone. And then I get a report from his neurosurgeon that referred him, and he's now able to ambulate independently with much better balance. Well, here's the largest one like this I've taken out. It's a young woman from Europe. And you can see where it sits all the way up to the foramen of Monroe. And the question is, can we take it out? So we do again the same thing. We're going to go cut the tentorium and then take it piecemeal. But notice the angle. We're coming right through the middle of the lesion. We can just follow it right up to its extent, and we take it out. Now we're all the way to the end. This is what it looks like post-op, and she goes back home. How do we get here? This is a lesion in the roof of the third ventricle, and there are different approaches. I think everybody would go interhemispheric. I like to go lateral to the choroid plexus. So then we go through the corpus callosum. We see the foramen of Monroe, the choroid plexus, but I like to go lateral. The books tend to write medial. The trouble is medial to the choroid plexus is where the fornix is, and I like that extra protection. Having the fornix, and I just use my sucker to retract it over. We identify the lesion, which is just below it. And in this particular case, I use a little CO2 laser to separate it from the internal cerebral veins, and it comes out very nicely. And this is what it looks like afterwards. Gone. More difficult now is this young man who's got a cavernous malformation that's sitting right at the end of the third ventricle into the aqueduct. So the exposure is exactly the same. So now we're going into the third ventricle. Here I need a rigid retractor because I need to hold over the corpus callosum that is hanging over. We are looking at the entrance of the aqueduct from the third ventricle. We take very tiny pieces in a piecemeal fashion until it's completely out. It's sort of nice because we can see the CSF then coming up from below. And it comes out very nicely. And there it is, pre-op, post-op. Pre-op, post-op, completely gone. And finally, the largest lesion that I've seen like this is in this young 6-year-old who had sudden deterioration, was operated on in his home country for 16 hours, severe blood loss, no diagnosis. They attempted embolization in Houston and also had to back out because of extensive blood loss. This is a cavernous malformation of the transverse sinus. Lesions inside the vascular sinuses are like AVMs. They are very, very bloody. Very, very vascular and have to be treated totally differently. When they are small, they are very sensitive to radiation, totally different than the rest of the cavernous malformation. So this is what it looked like. And my colleague, Dr. Albuquerque, you notice that the sinus is occluded from the lesion. He found one little vessel to enter it through an external branch and put all of this onyx into the lesion. That just shows you how vascular it was. When I operated, I made the craniotomy bigger. I cut the tent and the sinus on both sides. And then all we had left was this giant tumor, which was very easy to remove. Because of the onyx, you can see the sparking when I'm using the cautery. A tool I rarely ever use inside the brain. But for this year, it was just ideal, and we take it out completely. And there he is after surgery with his beautiful mother. Here's the post-op. And then I was very disappointed that she kissed him instead of me, who did all the work. But I have a nice follow-up from him. 1-year follow-up. He's the best in his football team, which is soccer, and a very good student. And then I have a 9-year follow-up. This is his original lesion. This is 9 years later. Excellent student and soccer player. And with his permission, that's a picture of him. So what have we learned? Well, we've learned how to get to these places in a safe manner with acceptable morbidity mortality. We made many mistakes, and they have taught us where not to go. So of great importance is knowing how you can get to these areas in a safe manner. And I don't think there's any place in the brain anymore that we can't get to. We've shared this in 2 volumes with videos in each one of those. Also, the Neurosurgery Journal has a classic collection of all my videos, which are available to anybody. So in conclusion, have mentors, learn the anatomy, learn this art, and I like a double pause. We know the first pause before we start, we want to make sure that the patient is oriented appropriately, that everybody's on board, the nurse, the anesthesiologist, the surgeon, the resident. The second pause is at the end of the procedure. I recommend looking at what you have done, determining whether you needed that much exposure or whether you needed more exposure, and then apply those lessons that you learned from the case to the next one. Details matter. I've emphasized that. I want to emphasize to start with easy cases. Exposure is everything. Progress slowly. Be confident enough to stop and enjoy this incredible privilege that patients entrust themselves to you. And don't forget to enjoy life. And that's me enjoying life. Wine country, bicycle trips, sailing, crossed the Grand Canyon 34 times, heli skiing, bike riding. I've never stopped enjoying life. And I think it's a nice combination, this incredible art that we practice called neurosurgery, and the ability to make a difference in so many people's lives. I thank you very much for your attention.
Yeah. Thanks a lot. It was a great talk, really. Probably Dr. Alvaro can moderate the rest of the session. Alvaro, do you want to say something?
Yes, thank you very much, Dr. Spetzler, for this outstanding lecture. I would like to ask to the young neurosurgeon to do some commentary or question. Please, Matthias.
Hello, Professor Spetzler, Professor Sileli, and Alvaro. It's a huge pleasure to listen and to attend your presentation. As you are really a huge master for all neurosurgeons, especially for young neurosurgeons. Your expertise and dedication in neurosurgery continuing to inspire countless generation of neurosurgeons worldwide, and your legacy you have built is a really a huge example for us, and serve as a guiding light for young neurosurgeons. And I would be really honored to ask you a question.
I'm afraid you're breaking up.
Intelligence and virtual reality. How do you see its role evolving? Are you listening to me?
Yeah,
Matthias,
but
your
can you
internet
listen to me,
is
Professor?
not good.
Yeah,
Okay.
you're
Are
breaking
you,
up.
it's okay now?
Yeah. Hi, Hero.
Okay. Can I ask you a
Yes.
question now? You leave for me. Sorry. As my reality continues to advance in medicine and in neurosurgery, how do you see its role
Matthias, we cannot
evolving in
listen well.
surgery, particularly in
I think he wanna ask the artificial intelligence, the
Oh,
value of artificial intelligence in
skin
our practice.
and
yeah.
surgical
You know,
planning for complex.
I'm just reading the book Nexus, which talks about artificial intelligence in a very, very
Sorry.
great.
Now,
Can you hear me? I think AI is going to make a big difference in medicine. There's no doubt in my mind it's going to help us make decisions much, much better with endless memory, etc. The real question is, will it also have a downside for politics, which we won't be able to handle?
Thank you so much, Dr. Spetzler. Dr. Dugrel, would you like to do some commentary or question, please?
Thank you very much, Professor Campero. Professor Spetzler, it was a great presentation. Thank you so much. You mentioned in your presentation, as I understand, one of the most important thing is you said 3 times anatomy, 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 like Professor Yaşargil. And I would like to ask you that what role should cadaveric simulations, virtual reality, or other training modalities play a role in enhancing these technical skills before a real case exposure? And considering the increasing difficulties in obtaining cadaveric training, do you consider these modalities can replace cadaveric training, or should they be used like a complementary in neurosurgical education?
I think it's really a very good point. Right now, I think it's complementary, but in other places, like in our own shop, we are very close to having a beautiful 3D model that really has detailed anatomy in it. And there's no doubt in my mind that cadaveric workshops are going to disappear as this becomes better and better. And the fact that it's endless, it will probably be very personal, so it's available to you all the time. It'll be a great additional tool.
Thank you.
You're welcome.
Thank you very much. Is another question, Matthias or Dr. Dugrel?
I can have another question also. Professor Spetzler, you have trained and mentored many neurosurgeons over the years, and you were teacher of many of neurosurgeons. As we are junior neurosurgeons who targeting to get the excellence in neurosurgery, what qualities, skills, or attributes do you consider most important in a trainee? How do you identify the potential for excellence in neurosurgical training?
So I can tell you that I think the first thing for a specialty like ours is you have to have passion for it. And by passion, I mean you're going to give it your all in order to get to be the best you can be. The other thing you have to do is I think you have to be compassionate. We have never accepted a resident applicant in our shop if a secretary or a nurse or technician said that when they came for an interview that they were treated with less than absolute great respect. I think if somebody feels superior to a secretary, they're not going to make a good neurosurgeon. Our specialty gives you incredible highs. Unfortunately, it also brings you very, very big lows. And when you have been involved in a case that has not gone well, it weighs heavily on you, and it should. And from that, you should learn.
Thank you.
Thank you. Dr. Spetzler, I would like to do a question. Do you believe that surgery as we know it today will disappear in the near future or not?
I wouldn't say the near future, but I think, endovascular advances have taken over a lot of the simple cases of aneurysms, so that the surgeon right now the microsurgeon is really confronted with the more difficult ones, the ones that require a bypass, etc. I have a whole talk on aneurysm. I didn't choose that because cavernous malformations are so nice in their anatomical distribution. But the same thing with aneurysms. There are those that you approach and those that you treat surgically, those that you treat endovascular. I think surgery is going to get better and better. But it's going to be at least another generation, another possibly 2 generations before the actual practice of surgery will disappear.
Thank you. Dr. Sileli?
There are many questions actually. The one that is telling Dr. Gabriel Vargas saying that endovascular training, we are thinking about it, and if the hybrid training good, if we have to be a candidate for hybrid training, endovascular and microsurgery.
I have trained quite a few fellows and residents who have become hybrid surgeons so that they do both the microsurgery and the endovascular. My personal feeling is if you really want to make a difference to one of those 2 specialties, you have to concentrate. They're very different in the instrumentation that's required, in the technology, and how to get there. And it's like anything else. If you want to super specialize and really make a contribution, you have to just concentrate on one or the other. But in many places where you're not going to be trying to push the envelope, being a hybrid neurosurgeon, I think is just fine.
What about changing our training technique in the future? Shall we change it in a different way, like using simulation methods and some other techniques instead of the current training techniques?
No, I think training is changing constantly. I mean, you already have the means to do endovascular practice in simulation that is very close to what you do in an actual patient, and you can hone your skills way before you ever put a catheter in a patient. We have so many tools now in the laboratory for training the aspiring young neurosurgeon, which were never available when I was training. So I think it changes all the time, and your job and my job is to allow this to happen and encourage what is good and discourage what we don't think is very good.
Yeah. The importance of the anatomy is very, very big, and Alvaro is one of the pioneers in teaching anatomy. What do you think about this, Alvaro? You have certain questions to
No, yes,
Professor Spetzler?
of course, like Dr. Spetzler said, the anatomy is a very important part of the surgery. The difficulties are in all the world is to get cadaver. It is very difficult, at least in Latin America, and it's so difficult to have a laboratory with a all head. Maybe you can You can have a brain or temporal bone and something like that, but not the whole head. So this is a big problem in all around the world. In US, not problem because you can buy a head and something like that, but at least in Latin America, it is impossible to do that. So that is a problem, I mean, for the neurosurgery.
I mean, that's why simulation is going to be so important.
Yes, that's right.
I mean, there are very good reasons why cadavers may not be available, whether it's for religious reasons or just feelings, culture, history, etc. So I think the new simulations, the new models that are being created are so good that it won't be long that they'll be just as good as a cadaver.
Thanks.
Do you have a simple conclusion sentence to be a master in neurosurgery for the young candidates of neurosurgery?
Yeah,
Do you have a simple comment?
Yeah. Practice and be humble. I mean, it's such an incredible privilege. Even today, the privilege of patients putting their lives into my hands is a responsibility, an awesome responsibility that we all have to take so seriously. And because of that, we have to strive to be the very best that we can be.
Dr. Sano, do you wish to make some comments on that?
Yeah,
Professor
hello.
Spetzler.
Hi,
Hello. I'm glad to you are very good and Nancy also. And but by the way, that Cabellnoma is approaching with everything, I think. So when I was young, I went to the anatomy room and to get the brain and always check before the surgery and draw it, and then after the operation, I checked it again. And so I did 3 times before and direct and after checking. So
you want to do a 3 pause, not 2 pause.
3 pause, yes.
Okay, I like that.
Yes. Yeah, maybe recently the young generation cases are very few. Our generation, so much cases, but nowadays cases so few. Then they must mimic, simulate, mimic the Robert and me, and then you do yourself afterward. That is the point, probably.
Yeah.
Yeah.
Yeah, we have been friends for a very, very long time.
Yes.
Any other questions from Yücel and Matthias?
I can share one more question also. Professor Spetzler, how was your perspective on the role of open surgery evolved with the rise of the endoscopic surgery, endovascular interventions, and concept of minimal invasive techniques? How did they affect your perspective on open surgery?
Well, if I was going to show you the aneurysm talk, you could see the evolution of the openings. And then finally going through the eye, over the eye, these tiny little incisions. I think you have to sort of incorporate whatever works and whatever works best. I think when you look at endoscopic surgery, there is a curve where the enthusiasm ends up taking on cases that shouldn't be taken on. And then we pull back and we learn this is the best indication for that. But endoscopic surgery, endovascular surgery, they're all part of this armamentarium of the neurosurgeon. And I think the most important test is to be able to look in the mirror at night and say, what I offered my patient was the very best for that patient, for their problem. Then you can sleep.
Matthias?
Yes, Professor Spetzler, and I fully agree with you that one of the most important tools for neurosurgeon is the neuroanatomical study and neuroanatomical practice and microsurgical skills, that it's important to get it in the laboratory. But another important thing for young neurosurgeons is to produce research papers. What's your advice, your suggestion for young neurosurgeons, especially in a time where to perform a research paper, sometimes invest a lot of time, and sometimes you are not able to reach the final publication due to a lot of rejections of the neurosurgical research articles. What's your suggestion for young neurosurgeons?
Yeah, I think we've all been there. I think in our residency program, you have a minimum of a year of research, and it can be clinical or it can be in the laboratory. And it includes also that you can go elsewhere. You don't have to be at home. I think one of the important parts of research is not that you necessarily have to produce something that is unique and will revolutionize the art of neurosurgery, but to appreciate what research offers, whether it's in basic science. So you can speak the language, because I think many of the advances that we've had in neurosurgery is a collaboration between the clinician scientist and the basic scientist. The basic scientist who can spend all of his or her time on a particular project, and the clinician scientist who defines the problem as it pertains to the patient population. So I think exposure to research is critical. I'm not so much interested in the huge flood of research papers that don't contain a lot. It's much better to be selective, but to be exposed to research as a resident, I think, is important.
Thanks.
We have some other members of the WFNS Spine, the Education Committee. Sabino, are you here?
Yes, Mehmet. Can you hear me?
Yeah.
Yes.
Sorry, it's some noise here.
Yeah.
Congratulations once again for this beautiful, beautiful lecture. And, it's precious for us to listen to all these precious advices for Professor Spetzler, that is a giant. And my greetings to him. And I cannot ask anything more compared to, my colleague, just consideration about anatomy. I totally agree, fully agree with you, Jill, and this beautiful. Thank you so much. And thank you once again for this beautiful opportunity.
Thank you, Sabino.
Thank you, Professor.
What about Roberto Leal? Would you like to tell something? He's not on the scene. Okay.
You're muted.
Microphone is out.
muted.
Sorry. I think we have to come to the end of that wonderful meeting. I appreciate the Professor Spetzler's time and very nice lecture, and also all the participants, all the discussers. Alvaro, would you like to tell something?
Just thank you very much again, Dr. Spetzler. Thank you.
Yeah. Thank you, Mehmet and Alvaro, for putting this on. I think this ability to communicate around the world is just spectacular. And
Yes.
I'm delighted to have been able to participate.
It was our pleasure. Thanks a lot.
See you soon,
Goodbye.
Professor. Goodbye.
Goodbye. Goodbye.